it's not necessarily an easy discussion because it mostly depends on how we define older patients, which obviously is not necessarily a consensus everywhere. My view is that many patients are able to receive standard of care until an advanced age, and it's mostly patients with comorbidity or over 75 or plus that who represent sometimes a challenge, and also patients who have very important frailty and comorbidity. So I suggest that standard of care apply to the vast majority of patients until, I will say, 70, 75, and if sometimes there are adaptations and things like that. But most of the things that I recommend to somebody who is 55 will be recommended to somebody who is 72. So I suggest that we focus a little bit on the more difficult to treat population and ask maybe Martin how he addressed this population, which you will call either slow go or no go in your old classifications.
Well, thank you, Gilles. This is a very important question. I fully agree. We have to differentiate, let's say, between what nowadays is probably the middle-aged, up to whatever 75 years old, or 80 in a good performance status, and the real frail patients. I would skip the real frail patients, but these elderly fit patients, I have two considerations. Well, essentially three. When it comes to standard of care, if I have the impression that it is a more aggressive disease, I still consider our mini-CHOP, which is frequently used in aggressive lymphoma, but not that much in follicular lymphoma. We published on that, and it is so well tolerated. Second thing, when the standard of care and probably mostly applied is bendamustine. And I think, especially in this population, it's very important not to force patients through therapy with G-CSF or similar, but really acknowledge that 2 to 4 cycles of bendamustine is a fully competent induction scheme, and that from the beginning on, you should reduce doses to 50 to 70 milligrams per square meter. And finally, don't forget the old-fashioned CVP, which is even better tolerated than bendamustine, and in combination with an anti-CD20 antibody, does do the job as well.
Any other comments by any other colleagues?
Gilles?
Yes.
And Martin. So I think that it's very important to discuss about the goals of therapy in a follicular lymphoma old patient, even with frailty, because so it really makes a lot of sense, the concept of functional cure that makes curable a disease that is not otherwise curable in terms of the biology and the clinical behavior of an indolent lymphoma such a follicular lymphoma. So I mean, if you're able to get enough free time from progression in an indolent lymphoma, even if there is a risk that is not very well controlled by the initial therapy because you're not able to pick the best, you can get exceptional results with this patient that allow this patient to live his or her life as long as enough as to get to this natural life expectation of an individual. That makes a lot of sense for a patient who is affected by a follicular lymphoma in the 80s or even older, but it can also be considered in relatively younger patient if there is a frailty status that prevent this patient from being eligible to a stronger treatment like full dose bendamustine rituximab or full dose CHOP rituximab. So I fully agree with what has been said before. Reducing the dose of the agents that we use, bendamustine, CHOP, but still keeping faith on the anti-CD20 component of the immunochemotherapy treatment is able to manage several alternative options that allows to tailor the right treatment to the individual patient that we are facing with.
Let's get the opinion of Grzegorz Nowakowski from North America, if you may want to say a few words about that.
Yeah, we have a similar approach, essentially trying to adjust the therapy to the patient performance status on comorbidities in those elderly patients. Bendamustine with dose reduction can be tolerated even by quite elderly patients. It is immunosuppressive, so you have to be careful about the risk of infections. But with the growth factor support and the dose reductions, majority of the patients can actually tolerate it quite well. What Martin has mentioned about RCVP, old good RCVPs are also there. We typically would omit vincristine if there's a lot of neuropathy or pre-existing conditions which can interfere with vincristine in those patients. R square had been used in those patients as well. I must personally say that probably in the elderly patients, lenalidomide actually can be quite myelosuppressive and also requires dose adjustments. So, and the longer exposure to therapy, I actually tend to favor just chemoimmunotherapy with those dynamic dose adjustments. And I'm saying here dynamic dose adjustments because we often start low, but if the patient tolerates and performance status improve, we can always adjust the dose of chemotherapy at that point. There's a lot of interest moving forward in investigation of other agents in this setting, particularly bispecific antibodies. But we know that in those frail patients, this could be a difficult therapy as well. So have to wait for the results of currently ongoing studies in the frontline setting to see if we can really expand bispecific antibodies or other non-chemo-like approaches to frontline treatment of those patients. Finally, radiation therapy is something which we had used historically to treat follicular lymphoma. In those very elderly patients, if the symptoms are related with the bulk of the disease, with compressive symptoms, but there are really not the candidates for chemotherapy for different reasons, sometimes even with underlying, I just seen recently somebody with underlying MDS, which really couldn't tolerate other therapies apart from maybe a single agent rituximab with pretty bulky disease. Radiation was actually able to debulk it quite well and really control the disease in those patients.
Thank you, Ida. I'm surprised that there is no enthusiasm for another treatment which I proposed to my frail or semi-frail older patient, which is basically GCVP or obinutuzumab CVP, which I think is well tolerated. Yes, there is a little bit the first infusion and maybe the cytopenia during the first cycle, but I think it's a very, rather than RCVP, which is really not optimal to control the disease, the additional small increase in heme tox and others, I think, make it favorable. Before to move back to you, Martin, maybe any insight from Australia, either Miles or Mike?
Yeah, I mean, I think your point about GCVP was sort of a thought that came to mind for us as well. I mean, I think when assessing patients and starting treatment, I always think about, we touched on it before, complications of B-cell suppression. And when I'm reaching for Gazyva or obinutuzumab as part of it, I'll think carefully about the backbone in these older patients. And Benda is so well tolerated generally by patients, but very protracted courses of Benda once you get out to multiple cycles, and particularly with additional B-cell suppression, I do worry a little bit about infection. So I try to assess my patients for their risk of recurrent chest infections and sinus infections, because it can become a real quality of life issue. So that's a big part of the consideration for me. And I think CVP can be a great backbone in that context if I'm a bit worried about Benda-associated immunosuppression.
Martin, you had a comment?
Just to add on, Michael, I fully agree. If you decide for a bendamustine backbone, especially in these elderly comorbid patients, I would avoid meanwhile obinutuzumab because of myelosuppression. And so if I'm going for Benda, I would go for R. And for CVP, I fully agree. Yeah, I do believe, and this is based on the Gallium trial, that combination with obinutuzumab is more efficient, but still is well tolerated.
Any comment, Francesca? Is there any parallel between these patients and patient with CLL maybe?
Yeah, the first thing is we can't use obinutuzumab frontline in follicular lymphoma, unfortunately. And yeah, I think the goal is to control the disease and RCVP or RCVP and Benda, adjusted Bendas, the regimes that we are using here for our patients. Yeah.
So I think we see that diversity of options to manage this patient between, bendamustine usually with rituximab, mini CHOP still for some patient with aggressive presentation, which can be used either with rituximab or obinutuzumab, rituximab CVP or obinutuzumab CVP. I agree that in the US, taking the R² regimen and again using the augment rather than the relevance schedule and adjusting the dose of len is also an option. So a lot of options, very personalized therapy as we do usually in follicular lymphoma. And maybe Marek, I see your hand raised, so maybe a last word before we conclude.
I would like just to ask, because sometimes we use for the really frail patient or elderly patients the immunotherapy only. So we start with immunotherapy and we just skip the chemotherapy to control the disease, etc. So do you think it's a reasonable option? I think that in the US it's widely used.
I think it's a reasonable option as soon as we think that any cytotoxic, either immunosuppressive or myelosuppressive therapy is not the option. And I think we all know patients that had received rituximab single agent, either the weekly schedule or eventually the Swiss schedule weekly plus 4 additional courses. We have done very well many years later. So I think, this is not the best way to have a very prolonged duration of response. We are aiming to 2-3 years, maybe 3-4 years before retreatment, but when we are dealing with all patients. So that's a very good point. And I think with this word, I think we have to conclude this session on follicular lymphoma. Thank you. And thank you for listening to this little discussion on the Lymphoma Hub website.